Our speaker today is Dr. Dana Goldman. Dana Goldman is the Leonard D. Schaefer Chair and Distinguished Professor of Pharmacy, Public Policy, and Economics at the University of Southern California. He also directs the Schaefer Center for Health Policy and Economics, recognized as one of the nation's premier health policy management programs. Dr. Goldman has authored over 200 articles and book chapters. He is a health policy advisor to the Congressional Budget Office, the Fred Hutchinson Cancer Institute, Covered California, and several healthcare companies. He's a member of the board of directors of the International Society for Pharmacoeconomics and Outcomes Research and the American Society of Health Economists. He serves on the editorial boards of Health Affairs, the American Journal of Managed Care, and is the founding editor of the Forum for Health Economics and Policy. His work has been featured in major news and media outlets. Dr. Goldman has also been elected as a member of the National Academy of Medicine. Dr. Goldman received his BA, summa cum laude, at Cornell University and a PhD in economics from Stanford University. And we are very excited to have you here today, Dr. Goldman. Welcome.
Thank you, Dean Robinson. It's a real pleasure and honor to be here. And if I'd known there were so many distinguished people in the audience, I would have come with better slides. So I want to apologize in advance. Just let me start by way of disclosure. I'll be showing you results from what I think is a body of work that really talks about how we should think about value going forward in an era of health reform, and this reflects work we've done with funding from NIH, Amgen, BMS, and Gilead. I take sole responsibility for any of the views expressed here, and I should note that I'm co-founder of Precision Health Economics, which is a healthcare consultancy involved in some of this work, and that I hold equity in that firm. So now that that's out of the way, I don't think it's controversial to say that how we price medical treatments, and especially drugs, is extremely controversial. You've seen a lot of the headlines about this topic. What's interesting to note, though, if you can see the small print, is the date. So this is not a new phenomenon. This goes back to when you could see there when we were talking about HIV. And I want to talk about that and put it in some of a historical context, and then come back and maybe at the end we can have a discussion about what the possible solutions might be. And I do think there are solutions, actually. We just need the will to do it. So what you see here, though, is one of the latest crises. This is the Epipen, and that's Heather Bresch, who's the Mylan CEO. And she was called in front of a congressional panel to talk about the Epipen. I was asked to do some testimony for the California Senate Health Committee, and you could see here that they invited Heather Bresch there, and they didn't. She didn't attend, but they made sure to put a placard there and actually videotape the empty seat, which shows you, the only reason I put this up is because it shows you that some of this is theater and some of this is real issues, and it's important that we distinguish the two. But one of the things that Heather Bresch said that I think is important is she said, you know, the prices you're hearing about are not the prices that people are paying. And in fact, what you see here are some data from Bloomberg News. And what it shows is the price over time of an Epipen. And you can see the list price was about $104 in 2012. And that list price went up to $276. And that's the source of a lot of the hand-wringing. That's a dramatic increase in price for something that is actually a generic, available as a generic in some sense, although the delivery mechanism is the pen, which is Mylan's contribution. But you can see that the the list price isn't the price everyone pays. For any of you who've bought a car and you've looked at MSRP, you know that the prices are negotiable. And in 2012, the price was being negotiated down to $102. What's happened over time, though, is the list price is going up, but the net price is not going up nearly as quickly. So you go from 102 to 157. That's a $55 increase, whereas the list price is going up so much. And we can talk about the reasons why. I think actually a lot of it has to do with rents that are in the pharmaceutical supply chain. And in fact, the people who are making money off this difference between the list and the net, including pharmacy benefit managers, are worthy of discussion. But the point, though, the broader point about this is that, this isn't just true of the Epipen. Here I've graphed normalized prices, list and net prices. And the point is, we don't know what prices are, and we don't understand what they are, and we don't understand who's really profiting off them. And so but really what we want to know is not so much the price. We really want to talk about value. And so what I'm going to do with a few minutes, and pull me off the stage when you'd like me to stop. I'm going to talk with the time I have about how we think about value. And so what you see here, for example, are some of the efforts by professional societies to start talking about value. So the American Society of Clinical Oncology, ASCO's got a report on value in cancer drugs. The American College of Cardiology has been talking about the prices of drugs for cardiovascular disease. Now, you mentioned in the introduction, I'm an economist. I've been working in healthcare for maybe 2.5 decades now. And you start to learn a lot, as a lot of you are, about medicine as you go along. But as an economist, I would never think to tell anyone about how to practice medicine. And so I would never give professional advice. And I think that these doctors who are looking at economics, I would like them to respect our professional boundaries as well. I think among a group of pharmacists, you can understand that. But be that as it may, I think let's keep going, and we can talk about why they want to get involved in this. And I want to talk about something, use some examples from HIV and cancer, and talk about what I call the innovation and access dilemma. So the issue is that in the short run, if we develop a highly effective treatment, what we really want to do is get unfettered access to that. And the problem with prices, high prices, is not that someone's making money. That's something we can always take care of in a progressive tax system. The problem is that the high prices might limit access to the drug. And so ideally, we should be setting prices at the cost of production. And we know for many of the products we're talking about here, that's pretty low. And so the idea is we'd like to have as low prices as possible. The problem is that we also want to develop new innovations. And we know that pharmaceutical research and development is risky. And in order to get people to invest in risky things, you have to pay them a reward. And so we've developed things like patents and market exclusivity and even research subsidies that are designed to generate the innovation we want and to reward the innovators. And so in the long run, what we really want are prices to be high for innovation, but in the short run, we want them to be low. And this cartoon kind of, it's patent rights versus patient rights. And the question is, how do we solve this? And I don't want you to think that this is just an academic debate. This played out quite dramatically for many years. And some of you may remember the development of highly active antiretroviral therapy in the mid-90s. I had just moved to Los Angeles in the early 90s. And I remember Magic Johnson, who played for the Lakers, having his press conference announcing he was HIV positive and announcing that he was retiring from basketball. And I thought, that's the last time I'm going to see Magic Johnson. Well, Magic Johnson, in the ultimate irony now, owns the Los Angeles Dodgers, and he's one of our most distinguished business people in the LA basin. And the reason why is we developed technology, highly active antiretroviral therapy, that allowed patients to live longer. But you can see there that at the time there was this debate over the pricing then, and it says patent enforcement equals death. And the way to think about this is to think about the improvements and to think about values, to think about the improvements in health. And one of the best ways to do that is to look at survival. So this is the probability of survival after being infected by HIV in 1984. And the goal for medical innovation is to move this out, to have people live longer. And if you look at 1994, we were actually starting to make some progress treating HIV. There were some drugs like AZT that came along of modest effectiveness. But by 2000, we'd shifted out their survival curve even more. And if you look at life expectancy for HIV, we went from 19 years in 1984, to 34 years by 2000. So we shifted it by 15 years. That's a remarkable accomplishment. So you take an illness that was afflicting people in their prime years of life, and you're adding, on average, 15 years of life and perhaps more. And so if you look at the discussion at the time, I don't want to do that yet. The discussion at the time was, look at all the profits that were going to the manufacturers of HIV. And actually, if you value that stream of revenues, it was about $63 billion. And you might look at that and say, that is a very large number, and maybe you think that that's not even ethical. On the other hand, if you take those survival curves, and I told you I'm an economist, and what are economists good at? We're good at multiplication. So we take the hundreds of thousands of people who get HIV, and we multiply that by the 15 years of life that each one gets as a result of this innovation. And then we multiply it by the value of a life year, say $100,000 or $150,000. And what you come up with is a number of about $1.4 trillion. So another way of looking at this is to say, of the value created to society from HART, about 5% of the value was returned to the innovators. And so that $63 billion, which sounds like in some ways an unethical number, becomes a 5% of the return to the innovator. And it raises important questions. In fact, you could even argue, as some have, that the returns here were too low, that it doesn't encourage enough innovation. That's something I'll come back to at the end. Here again, you see doctors denounce cancer drug prices of $100,000 a year. I think they need to just stay doing what they're supposed to do. But similar issues arise with cancer. So the thing about HIV is it's an easy example for me to choose. And it's easy because it's affecting people when they're young. And cancer, we know, has this age prevalence profile. It hits people at much older age. And treatment is really often viewed as very low value. It's expensive. It rarely improves survival. And actually, the treatments can be quite toxic, as many of you know, and it can decrease quality of life. And so what I want to say is that the way we're thinking about cancer may not be the right way that patients are valuing it. So let me give you an example. This is data from a clinical trial of ipilimumab, which is used for metastatic melanoma. And these are data taken from a trial that was published in the New England Journal of Medicine. And what you see there is, in yellow, is the survival curve for the control group. And what I want to point out, here's survival measured in months, because metastatic melanoma is a very pernicious disease. And you can see that by the end of the study, no one had survived in the control group. Okay? And what happened is melanoma therapy, ipilimumab in this trial ends up having this effect on survival. Now, if you look at median survival here, it was about 3.6 month improvement. So you're going from 6.4 months to 10 months. And the New York Times wrote an article on the front page of the business section saying that here's a drug, it improves survival 3.6 months, and the cost, I don't remember the cost actually, but it's probably around $100,000, like all cancer drugs are. And that's where a lot of the focus was. But what I want to point out is the following, that it turns out about 1 in 5 patients survived through the end of the study, and it looks like this is part of an exciting class of immuno-oncology agents. And you can see that it has a durable survival effect. And so there's a 1 in 5 chance that someone's cancer might actually be curable. And there's a very different perception of value if I say to you, here's a drug that has a 1 in 5 chance of curing someone's cancer, versus here's a drug that has median survival improvement of 3.6 months, but they're the exact same drug. And so, but the point is that people are deriving value based out here. And actually, when you talk to patients about this, what they say is they'd like to take that chance at that right tail survival. So you can go and do a similar type of calculation for cancer drugs. Here's one for Gleevec, where we showed that first-line therapy, it looks a lot like the HIV story, where 9% of it's $8 billion in spending on Gleevec in net present value, but about 10%, there's about 80 to 90 billion worth of value going to consumers in the form of health benefits. Now, one of the other issues that comes up when we talk about innovation is that, well, of course, you're talking about the innovative drugs. What about the people who do the follow-on therapies, the second-line therapies? And I always find this kind of ironic as an economist, because we like competition. You know, competition is what lowers prices. And so if someone comes along and builds another version of Gleevec, that should induce some competition into the market. But sometimes we tend to call that Me Too innovation. But the other thing it does is it provides treatment alternatives for other consumers. And so we looked at new second-line therapies. And again, you see that there's a lot of value going to manufacturers. So what do I think are the lessons from these two examples? Well, the first is that we shouldn't be talking about launch prices. You know, we know that there are ways that we can get prices down, and price discounts have become very important. And the other thing I know is that for the most successful products, the innovators are capturing only a small fraction of the value. Now, there are a lot of drugs out there, by the way, that aren't innovative. And we may be spending a lot on them. And I want to come back to that. But the other point here is that value is not just price times quantity. That is, the price times, let's say, the quality adjusted life years. And I want to talk a little more about that. And I want to use an example from cardiovascular medicine. But I also want to say that I want to come back to the goal of healthcare spending, because you mentioned that I serve on this CBO panel of health advisors. And when you go to Washington and you talk about Medicare, it's a spending category. In fact, Ben Bernanke, the former chair of the Federal Reserve, I think he famously said once, the United States is a health insurer with a Navy. And he's kind of right, because we spend about $1.4 trillion a year on healthcare, but we think of that as spending, and we don't say, what are we getting for our money? And actually what we've seen is that death rates are coming down. And that's especially true in heart disease. Cancer, which I told you about before, has been, you can see there's been dramatic declines for both men and women in progress in heart disease. And part of the reason that that's happened is because of drugs, well, there are a couple of reasons. One of them is public health efforts. We got people to stop smoking, which is probably one of the most important innovations in terms of improving population health. But we also developed antihypertensives and statins, and it turns out statins have a similar story. We've probably generated about $1 trillion in value, and about 238 billion of that has gone to the manufacturers. But the reality is that there are millions of Americans who are still not meeting their cholesterol goals. These are some data here. And this is relevant because there's a new class of, well, actually, let me say one point about this, which is, so if you look over here on the right, these are people whose LDL, which is the bad cholesterol, is above 190 milligrams per deciliter. There's about 11 million of these people, and about 2 million of them are being treated and haven't reached the goals, and about 9 million of them are untreated. So we have a problem of undertreatment in this population, as well as the fact that there are millions of people who aren't being treated in that goal. And, you know, part of the reason is people don't comply. We worry a lot about adherence, and what we know is that, for example, if you charge people a $10 copay for their statins, you'll find that regardless of their cardiovascular risk, only about 60% will take their medicine a therapeutically optimal amount of time. If you double that copay, you'll get a 12 percentage point reduction in compliance. So we know cost sharing matters, but we're kind of getting sophisticated about this now. Plans are offering free statins or at very low cost. We have generics available, which are very key to offering low-cost alternatives. But what I want to do is suggest to you that there are other pricing models that we could do here for innovation. So I just want to spend some time and go through this chart. And what I want to say is that if you think about drugs, and you come back to that, what I was talking about with the value and innovation dilemma, drugs are not like other things in healthcare. They're not like an office visit. In fact, they have more in common with something like the Microsoft operating system. So Microsoft spends a whole bunch of money on R&D and hires programmers, and then they shrink wrap their product and they sell it to you. Now, Microsoft does not charge you every time you turn on your computer, right? They could. They could have priced it so every time you use it, you end up paying them, right? In some ways, that makes sense. You use it more, you should pay more. But that's not how they did it, because what they want you to do is use it as much as possible. So what you buy is a license to use the product. And that license is designed to reward the innovator for developing the product, but it takes away the incentive for you to limit how many times you're going to turn on your computer, because you got to pay 10 cents to Microsoft every time you do it. And if you think about drugs, we went through an example with statins. One way you could have done things here is, instead of charging a $25 copay, for example, which is our traditional strategy, you could charge a $195 license. And that license would give you access to however much statin you and your doctor think you need. Okay? And that can be paid by the insurer. And what we showed is by doing that, you suddenly remove any of the effect of copay on use, and you can magically improve adherence from about 65% to 80%. And in a population of about 10,000 people, that means 127 fewer hospital stays during the year. Now, the health plan ends up paying the same amount. The manufacturer, in this example, ends up getting the exact same profits. But who's won? Society has won. There's actually an advantage. We've won, well, the hospitals have lost, actually. So the hospitals may not like this. But society, as the patients have won, they get better compliance. The plan actually saves some money, and they can divide that up, and you can give it back to the health plan, you can give it to the manufacturer, you could give it to the patients. It's, you know, it's a matter of negotiation. But the point is, if we get out of this model of paying per use and thinking about rewarding the innovation, we could maybe do better. Let me give you another example of how we might deal with this. So I want to come back to the statin example again. So it turns out, probably a lot of you have heard about the new class of Pcsk9 inhibitors. So these are more expensive biologics that can be used for lipid lowering. They've been tested for patients who have failed statin therapy, and failed, I'm going to put in quotes. It depends on what you mean by that. And there's going to be there is a huge debate over whether, and in the recent trials, they can get these lipid levels down to about 30. I mean, it's remarkable. But the question is, does lowering cholesterol actually improve health? And some of you may have seen the Fourier study that was recently published, which showed that it did actually reduce cardiovascular endpoints by about 15% when you gave patients these Pcsk9 inhibitors. But there was no difference in mortality between the treatment and the control group. So we get cholesterol levels down. We know we get fewer cardiac events. There was no difference in mortality, but the study wasn't powered to do it. So we went and looked at this and thought about this and modeled out what the potential benefits would be. And depending what you think about that mortality effect, there might be maybe between $400 and $800 billion in value out there from these drugs, depending on the rates of efficacy. So the answer here, one way, so what do we do about this? Well, the right answer here is we should contract on outcomes. We should not be, so the health plans are out there saying we don't believe this cholesterol hypothesis, or we're worried it's not going to save money, and the manufacturers are saying we believe in our drug. The right way to deal with this is to write a performance-based contract, and depending on the outcome, you know, you could reward them, and I'm not going to go through these numbers in any detail. So the lesson from CVD, I think, is that statins have generated a lot of value, but there's still a lot of residual risk. And there are ways that sophisticated ways to price these so that we don't end up in the world where the health plans just say we're going to limit access, and the manufacturers just say, you know, how do we get patients, motivate patients to help us deal with the blockage that we're seeing at the plan level. And the right way to do that is with value-based pricing. And actually, we're seeing some of that in this space. I think Amgen just announced that they would give the money back if the patient ends up being hospitalized. And, you know, that's the most American thing there is, right? Money back guarantees. You know, if my operating system doesn't work, I get my money back, and it should probably be the same. So I think there are opportunities for contracting that would solve this. You know, I want to talk, though, there are some misalignment of incentives that make it much harder, and I want to talk about Hep C, which has been the other issue. Now, Hep C, you may have seen some of the headlines. If you didn't, then I'm impressed. But it costs, what I think $1,000 per pill, or $87,000 for treatment, or $100,000. I find it ironic in some ways. If you think about talking about price per pill is probably the least valuable thing we could do in healthcare. If you think about it, one way to lower the price per pill is to have people take more pills. So if I go from 500 milligrams to 50 milligrams, I can lower that price by a factor of 10, and you have to take more pills. In fact, the most valuable thing we can do in healthcare is get people to cure their disease with one pill. So what we want to do is fewer treatments, not more. And so that's not the price we're interested in. But it turns out Sovaldi and Harvoni, which are the two drugs manufactured by Gilead, they're not the most expensive drugs. Here are some drugs here and actually one of them is the CML treatment that I was talking about earlier that's $150,000 per treatment, and that goes up to $537. So why was Hep C at $100,000 so? Why did it resonate so much with the community? And the answer is not the price, it's the prevalence and the effectiveness. And it comes back to what I said before. If you develop a drug that's highly effective, it seems highly unethical to prevent access. And if high price is limiting access, that's bad. And if it's limiting access for a lot of people, that's going to generate a lot of attention. So it's not just the high cost, it's that you're multiplying it by a lot of people. And, here's some of the headlines we saw, and again, Gilead got pulled in front of Congress to talk about how they price their drug. And the problem here, in some ways, is the misalignment of incentives. So let's talk a little about Hep C. It's a liver disease. You get this virus, and what happens is it can remain latent for quite a bit, but you can see that there's a cumulative mortality. So these are people with elevated viral levels, and their mortality, it can take 10 to 20 years to show up. And actually, this is, in some ways, the infections were all occurring worldwide in the past due to the virus in the blood supply or because of lack of sterilization of medical equipment. These are things we're getting a handle on globally. But the problem is the costs are going to appear. So the infection is in the rearview mirror, but the costs are looking out through the windshield. And the question is, what do you do about it? And I'm going to skip this. And the problem, though, is that if you look at how much payers are going to have to spend in order to do this, if you're a private insurer and you say, okay, let's say I cure someone's Hep C, what does that mean? Well, what it means is you may prevent liver complications down the road. But who benefits from that preventing those liver complications? It's actually the Medicare program, because Medicare would have to pay for the liver transplant. So here you are, a private payer, and the company wants to charge you, let's say, $83 billion by our estimate if we treated everyone aggressively by 2019. And the costs of this, we know, as a society, are going to pay off. In fact, we have the opportunity, if we treated everyone right now, we could eliminate Hep C from the planet. I mean, we did that with polio. The benefits of that accrue not just to the current generation, but to all future generations. Okay? The fact that we are not, most of us in the room, are not having to worry about polio is something we should figure out. How can we reward past generations for solving that problem? Because we're benefiting from it. And so, it takes 15 years in this model to cover the costs, and actually, Medicare ends up saving $5 billion. So really, if you think of it as a social problem, the government should be buying out the patent to Hep C and giving it away for free. And that would be the optimal way to deal with this. And the problem is we have no system for thinking about that or for sharing that. Now, what's interesting is in countries with national health plans, they do have a system for doing that because all those costs have been internalized to the countries. And so, you know, it was very interesting that Sovaldi, when it was reviewed in the United Kingdom by NICE, which is the group that kind of evaluates drugs for effectiveness, they said that they would cover it because they knew it would help. It's a very effective drug. But what they also said is that they would limit access to it. Okay, and why? This is a kind of an unprecedented thing. You've got something that's effective. We know it can eliminate the disease, but they said they wanted time to develop the infrastructure to support it. What that means is they had budget pressures and they don't want to give it all to the manufacturer. So affordability is certainly an issue globally, and the problem is we're seeing it take place through things like budget caps and restrictions on the number that are going to be number who will be treated, and that has more to do with affordability than value. So my point is this debate is going in the wrong direction in many ways. What would have been the right thing for this is if the manufacturer had gotten together with various insurers and the government and said, can we develop a performance-based risk-sharing agreement where if we agree that we eliminate Hep C in the United States, we would get some money back, or even say the following to Medicare. For if you end up seeing fewer liver transplants, that's going to save you $5 billion. Will you share some of that money with us? So I think, you know, the point is that private payers are burdened with too much cost and too little benefit. And the result is we limit access, and we're all worse off when that happens. You know, especially with infectious disease, you know, because we all face the risk that we might get Hep C for those of us who may not have it right now. Okay, so I think I've been talking for quite a bit. I would like to conclude, and maybe we do some questions, or I don't mind talking more. I don't know how long I've been talking. So, oh, no, I'm doing well. So, okay. But so I'll just say the following is that, you know, the problem here is we've misaligned short-term costs and long-term benefits. And we now understand how to design contracts and do innovative pricing in a way that it doesn't just have to be, and the way the debate has gone is to beat up the innovators. And I think that the unfortunate thing about the Sovaldi example is that a company developed a cure, not a treatment, a cure. If they had come up with a treatment for Hep C and said, oh, you can take this and pay us $10,000 a year for the rest of your life, no one would have batted an eye. That would have been really affordable. But, you know, what they did is they came up with a way that you could take a medicine for 12 weeks and get rid of the disease completely, and they tried to price it for that value, and everything went haywire. And so, you know, the answer is the signal it sends in the marketplace is let's not develop a cure. You know, and this pervades healthcare generally. So, you know, for example, there's a new treatment under review. It actually, we know it reduces cardiovascular disease, it reduces diabetes, it may reduce the incidence of cancer, it prevents obesity, and that treatment's called exercise. Okay? But no one's out there being paid to get anyone to exercise, and yet that may be the most valuable intervention we could do. And the question is, how do we reward someone in our healthcare system who figures out how to get everyone to exercise? And, you know, hopefully we'll be able to discuss that as we go. Thank you.